Anyway, so I hope that at any point in this presentation, people feel free to stop me and ask questions. It would only be fair if some of the speakers got their own back. Now, I'm splitting my time slot with my colleague, so I'm going to romp through this talk. So what is the continuum of care? And I think it's probably all phases of illness from diagnosis to end of life. And it's not this Canadian show, which is actually not bad. And I'd like to congratulate the Americans. I believe that the women's ice hockey team beat the Canadians for the Olympic gold medal, so congratulations. So perhaps this is a more realistic view of the cancer continuum, that we start out with presentation, screening, diagnosis and treatment. And then while all survival curves eventually tend to zero, nobody gets out of here alive. There are those who are not going to be cured and who need specialist hospice care and palliative care, and those who hopefully are cured. So why do I love working at Bon Secours Cork? And someone said, don't say clean floors. Well, I actually think it's really important. You walk in, the place is spotless, people have got a good attitude, you can eat the food as opposed to being embarrassed seeing what dross is being fed the patients in some other places. Now, it's actually dangerous for the consultant staff, because instead of the college 10, or as well as the college 10, you've got the Bonds 10. But there's also a can-do, patient-first attitude. And we're able to do research, and we're able to offer patients a gold standard of care. But, there are challenges, and it's only through being honest about the challenges that we can move forward. And I think that the new build and partnering with UPMC solves some of those challenges. And as we've alluded to today, it gives us other challenges in how we're going to structure, measure, and deliver our work, which really is all about patients. So I think that one of the big gaps we've had is that while pastoral care does a great deal of very important work, there are patients who need more bereavement counselling, and that's something which I'm hoping that will come as the oncology volume increases in Bonds Cork. But we're aware that our population is aging, is increasingly socially isolated, is increasingly obese, and we have to be able to recognise and meet these challenges. So I always tell the medical students that cure is like a Christmas cake. Most of the cake is surgery. In the middle is radiation oncology, or marzipan, and the icing on the top is medical oncology. So you'd have to say, why should medical oncology be coordinating cancer care at all? Well, I suppose it's not just the fact that we get involved with surveillance for recurrence, that apart from palliative care, we're the ones with the patients towards the final steps of their cancer journey. And a lot of the time now, I can tell a patient, I can't get rid of this, but with your help and with palliative care, I can help you achieve meaningful years with your family. And I think that that's really important. And the other thing about medical oncology is that we're fanatical about research, and we're hungry for every percentage of cure, but we're also very aware of how toxic our treatments can be. So this is the ideal MDT. And, I think that we don't have everything, but a lot of these bubbles are filled at Bonds Cork. But the challenge of the MDT, which Dr. Hacking alluded to, is getting the right answer to difficult questions. And this is a case recently of a patient who had a near obstructing, localized, perforated, walled-off primary and metastatic disease. And there's lots of good reasons to just go straight to chemo, because it's definitely fit for chemo, and there's other good reasons to go for surgery. And as it was, the patient had successful surgery with Mr. Barry and will be starting palliative chemotherapy shortly. So we, participate in the Bonds Group Awards. It was nice to be nominated. We'll get the Oscar next year. And then once the patient has come through the MDT and seen the hematologist or the oncologist in rooms, their case comes back to the chemotherapy planning meeting, and we've got a lot of people at that meeting because there's different pieces of the jigsaw, and quite frequently we'll be asking our excellent liaison nurses to phone the patient, check they haven't had a toxicity that didn't bounce them into hospital, they didn't ring us, but before we order the next chemo, we want to be sure it's safe. And we're very lucky to have the dietitian as part of our team. Now, what Ger Markey, our day ward manager, and Dr. Con Murphy have done is help us to move from paper diaries to electronic Swift queue. And this is now going to be used to feed information to our billing services. And it's also going to help us to safely follow colon cancer patients. Because, you know, this is a reasonably complicated way just screening for recurrence. It's nothing to do with survivorship. It's nothing to do with the peripheral neuropathy, the sexual dysfunction, anything like that. But this is the gold standard we have to hold ourselves to. And if patients don't turn up, these days it's our job almost to track them down and say, sorry, you didn't come in for your year 3 scan, what's going on? Because otherwise my learned friends in the High Court will make mincemeat of us. So another initiative which is providing, you know, quality of care is the triage log sheet. And this was started in the UK after several unnecessary deaths of patients on chemotherapy. And Mairead Murphy, our liaison nurse, has done, one of our liaison nurses, I should say, has done great work rolling this out. And yes, it's paper, and I'm sure it will be electronic in due time, but it does mean that even if it's a relatively junior nurse or doctor taking the phone call in the first instance, they are guided towards how sick is this patient and what do I need to do about it. And all of these decisions are run by senior clinicians. So we do measure our data. I've kept a prospective database of my lymphoma, and we published this at ASCO last year, but I was looking at it not from a point of view of the cost effectiveness analysis we ran, but we're not doing too bad when it comes to our overall survival. And I've chosen the patients who were higher risk at Bons Cork compared to the national average. And I'm sure I need to tweak that a bit more and correspond with the very helpful statisticians at the National Cancer Registry. But I think it's pretty acceptable. I mean, the UK figure for survival, you know, in very similar to our group, is less than 60%. And then Dr. Murphy did a lot of work with the NCRI looking at disease-specific survival, and the closest statistic that the NCRI have is net survival. And again, you know, there's a variety of reasons. Our patients are healthy, they tend to be compliant, but I think you can say that this goes to show a certain level of quality of care. And then I looked recently at our stage 3 colon cancer data, and we're coming in, you know, 14% better overall survival at 5 years, with a relative dose intensity touching 90% of chemotherapy in patients whose Charlson comorbidity index varies from 0 to 2. So when a patient comes back to clinic, you know, our job is to reassure and examine them, to help them plan a return to normal and new normal, talk about their schedule of follow-up. We've got to communicate this to the GP. More and more I've been offering to CC the patient on it. And then we need to kind of do the fluffy stuff, which is probably just as or more important. We talk about feelings, depression, counselling, sex, fertility. And, you know, this is part of the reason that I think oncology is a key part of the cancer continuum. And, you know, I'm passionate about survivorship because we hurt people. We don't want to hurt people, but we do. As the drugs and the radiation and the surgery becomes less toxic, perhaps we do less damage, but we cure more people and generate more cancer survivors. And I don't want patients just to survive, I want them to thrive. And for that we need GPs, and we need lots of other healthcare professionals, physiotherapists, and we do need psycho-oncology. And the thing is, you know, patients don't fail drugs. The drugs fail the patient. And, you know, that's when you have to gather your courage, go into that room, sit down and have a chat and talk about what their goals are and what my goals and all of our goals might still be in that scenario. But, you know, the future is bright. We've had fantastic speakers today from both sides of the Atlantic talk about the work that's going on, and Dr. Murphy's going to talk about some of the work we're doing in Bonds Cork to make the future even brighter. But in the last month, I've had 2 cancer survivors breastfeeding their newborn babies in rooms, and that just makes me so happy. I have cancer survivors who said, you know what, I don't like being an international management consultant. Now that I'm over this lousy cancer, I'm going to retrain as a teacher, and I'm much happier. And you know, our job is to get out of their way and help them reach their goals through excellent care and collaborative research. Thank you.